Hi, everybody. This is Dr. Ching from the OMM department, and thanks for having me come and speak to you about headaches and their musculoskeletal considerations. I hope everybody is doing well. So I wanted to start this presentation off with a case, which is a 17-year-old male, so he's almost an adult, with a history of intermittent, mild, and moderate migraines since he was 13 years old. And he came to the emergency department with new onset paresthesias. So what had happened was that he had a nosebleed that morning, and then he fainted. And then when he came to, he was breathing quickly, and he had paresthesias in his arms and legs. And he also had difficulty moving his hands. Then he started to complain of a headache. So they went to his doctor, but his symptoms had significantly improved by the time they went there, and he had a normal neurologic exam. So primary care doctor sent him home. On the way home, he started to have left-sided numbness of his body. It started in his hand and his foot, and then progressed to the entire left side of his body. They went to the ER for that, and did not have any problems with talking or walking or mentation, no nausea or vomiting. He had no loss of consciousness during this episode, and no incontinence. At the ER, his neuro exam was unremarkable, and presumptive diagnosis was a migraine variant. Then 2 days later, he had 2 episodes of numbness in the migraine. And then 3 days after that, he had bilateral numbness of his arms and his legs that worsened, along with shortness of breath, left-sided drooping of the face, and slurred speech. So they went back to the ER, and his stroke score was 0, but he was admitted for observation. So they got an MRI, MRA, and MRV that were all negative, except he did have a pineal gland cyst without any obvious compression. His labs were normal. He was put on propranolol in addition to his usual migraine medication. And I think he was at St. Francis with the OSU Peds, so OMM was done in the hospital, and that actually helped his headache. So then he was followed up by Cook's Children's Headache Clinic in Dallas. He had started to have sensory and motor auras with his migraines, and they switched him from propranolol to amitriptyline because of pre-syncope episodes that he was having. And they also started him on Topamax. Of note, on the initial OMM clinic visit, he was noted to have a history of anxiety. So he came to us about 4 months after his initial episode. Shortly before the visit with us, he had left-sided numbness and weakness. Cook's Children's had increased his amitriptyline dose, and they did a follow-up EKG, and that showed conduction delay. So they sent him to cardio. But cardio did not think this was from amitriptyline because the corrected QT interval was normal. Just to add to the complexity, though. At his OMM clinic visit, he notes that he had chronic neck and back pain. He does 4-H, and he shows cows. And how he explained this was that the cows knock him over, or they hit his head. So he's had multiple injuries from showing cows, and at least 1 concussion without loss of consciousness. But he's had multiple head trauma before. He has also had multiple sinus infections over the past year with 5 rounds of antibiotics. So he'd seen ENT, and sinus surgery was scheduled. On physical exam, he had sinus tenderness ×4, and throat was irritated. Neuro exam was unremarkable, and psychiatric exam was pretty normal as well. On osteopathic exam, he had somatic dysfunctions from top to bottom, pretty much. So we saw him about every 1 to 2 months for OMM. He had decreased frequency of the migraines with less motor and sensory auras with OMM. Also had decreased frequency of the tension headaches and improved back and neck pain. So he was able to wean down on the amitriptyline and Topamax. And he had been off of amitriptyline for several months and Topamax for 3 weeks, but then he got an optic migraine and was vomiting. And so now he's back on Topamax. And our plan was to see him every 1 or 2 months for OMM as needed. So I thought this was an interesting case for you because he's got a lot of different components of headaches that we can talk about here. And he's also got a pretty complicated migraine, a complex migraine, and OMM can sometimes be helpful for this, especially if there's a history of head trauma. So we're going to just run through the red flags really quickly. So if you've got a headache that's a thunderclap headache, or the worst headache of your life, or late onset, which means after 30 years old, of a new headache. Any headaches associated with fever, rash, or stiff neck could be concerning for meningitis. A progressively worsening headache is concerning. Headaches associated with neurosigns or symptoms other than the usual aura is concerning as well. And in our patient, he had changing neurosigns and symptoms. Any headaches associated with mental status changes should be investigated further. And then headaches associated with exertion, sexual activity, coughing, or sneezing can be a sign of increased intracranial pressure, so needs to be investigated further as well. So I'm just going to briefly run through your primary headaches. The International Headache Society defines 3 main types of primary headaches, meaning that there are no red flags and other pathologies have been ruled out. So migraines without an aura have to have at least 5 attacks with the following criteria: lasting 44 to 72 hours, at least 2 of the following criteria. They have to be unilateral, pulsating quality, moderate or severe intensity, and or aggravated by physical activity. And when the headache occurs, you have to have at least nausea and vomiting or photophobia and phonophobia. So there's a pound mnemonic that I think is helpful. And if you have 4 out of 5 of the criteria, it's most likely a migraine. If you have migraines with auras, they can involve visual, sensory, motor, or speech changes. So our case, he had numbness and tingling, and then the facial drooping and whatnot. The important thing is they need to be fully reversible. Tension type headaches can be severe enough to be called migraines by lay people. So I can't even tell you how many times people come in complaining of migraines. And when you ask them more closely about the criteria and the symptoms that they're actually having tension headaches. But even after you tell them that, they'll still keep calling them migraines. The significant thing about tension type headaches is that they have to have minimal neurologic symptoms and no neurologic signs. A lot of the symptoms are from muscle tension. They can be episodic or chronic, and they're the most common type of headache. So they last for 30 minutes to 7 days, so significantly longer than the migraines. And they have band-like tension, mild to moderate intensity, although sometimes can be severe, usually bilateral, and no aggravation by routine physical activity. And then the last part of that is they have to have one of the following bullet points. So no nausea or vomiting, and then either photophobia or phonophobia, which I did not write the verbiage for that, so I apologize. So cluster and trigeminal headaches are rare. Really important for you to keep the criteria of these in mind, though, because they're unusual. So you have to be diagnosed. You have to have at least 5 attacks with the following criteria: severe unilateral orbital or supraorbital pain lasting for 15 to 180 minutes. So you notice that they're shorter episodes than tension or migraine headaches. And they have to have at least 1 of the following ipsilateral signs: conjunctival injection, lacrimation, nasal congestion, myelocystrosis, eye edema, forehead or facial sweating, and or a sense of restlessness or agitation. So I don't know if you had any of these symptoms that were on the contralateral side from the headache, if that would still qualify as possibly a trigeminal or cluster headache variant. But that would be a good question to ask of your neurologist if this ever occurs. The other thing is that the frequency can vary quite a bit. It can be from every other day to 8 times a day. And when that happens, of course, it's very problematic because it's severe pain. And it can be seasonal or throughout the year. You know, the typical case is somebody who just has a cluster of headaches one time a year, but it can be seasonal. And then you have your other primary headaches, and there's just kind of a bunch of other primary headaches that are there. So then you have secondary headaches. So secondary headaches are a headache as a result of another disorder known to be able to cause headaches. So there's a bunch of other criteria. They have to occur in close timing to the other disorder, or there's an evidence of a causal relationship, or when you treat the other problem, it goes away within 3 months or less. So lots of different types. It can be secondary to head or neck trauma, vascular problems, non-vascular intracranial disorder, a substance or its withdrawal, infections, disorders of the cranium, neck, eyes, ears, nose, etc. Psychiatric disorders and or cranial neuralgias, cranial nerve neuralgias. So cervicogenic headaches are something that we in the OMM clinic come across quite a bit. Basically, that is a headache caused by something going on in the neck. However, because of various reasons, such as gating, the gating phenomenon, the patient may or may not actually report pain in the neck. So that's where your physical exam part comes in. The clinical criteria, which is not completely agreed upon, are unilateral headaches, signs or symptoms of neck involvement, episodes of varying intensity or duration, so moderate or non-excruciating pain, pain starting in the neck and then spreading to the head. The other interesting thing about cervicogenic headaches is that you can have other symptoms associated with it, like nausea or vomiting, dizziness, photophobia/phonophobia, or blurred vision in the ipsilateral eye, or autonomic signs or symptoms. You can even have cervicogenic vertigo. So this is an interesting phenomenon that I experienced as an intern. I think I was doing a weekend call or something like that. And, and then on Monday, I woke up and I had vertigo. And I didn't know what was going on. And I didn't have any other symptoms. And so our OMM doctor at the hospital worked on my neck and the vertigo went away. And it was because I had cervicogenic vertigo. So what happens here is those small neck muscles get tight, and that causes improper input because those small neck muscles are proprioceptive. And so they're giving the brain the wrong information, and then you end up with vertigo. So there's some thinking now in the PM&R and concussion fields, that some of the symptoms from post-concussion syndrome are actually from neck-related issues. Because if you look at that list of associated symptoms like nausea and vomiting, dizziness, photophobia, phonophobia, blurred vision, etc., those can be caused by neck issues. So that's an interesting development in post-concussion syndrome that I thought I would mention. So the other criteria are interventional diagnosis. Of course, you can't do this on everybody with neck pain and headaches, but from a research perspective, it's been interesting. So what they do is nerve blocks under fluoroscopy to determine what structures are causing pain. And the AA, C2 to 3 and C3 to 4 are the most important ones, and C2 to 3 cause about 70% of cases, at least in that one series that they did. So if you have somebody with dysfunction at C2 to 3, it's usually associated with a headache. At least that's what I found. So let's talk about different causes of headaches. So when I think about OMM, and when I have somebody coming in with a chief complaint, I'm really trying to figure out what is causing the problem. So with a headache, it could be a circulatory problem like vasoconstriction, it could be lymphatic congestion, or seasonal allergies, which is very common in Oklahoma, as you know. It could be a muscle-related problem. It could be a trigger point. Head or neck posture is very important. So pillows, soft beds, these especially unfamiliar pillows and softer beds than usual usually happen in the hospital. So this is one reason that a lot of our patients that we get consulted on in the hospital often tend to have headaches, is just because of the unfamiliar pillows and the soft beds. Forward head posture, so you have your head more forward than it should be. This is very common in people who are working on the computer a lot or watching TV, or they have vision that hasn't been corrected, or post-intubation or post-surgical. So if they're intubated, their head's extended, and they tend to have pain and headaches for that reason. I'm going to talk about the myodural bridge in a few slides. This is a more recent anatomical discovery, which has been very interesting. Headaches can also be caused by irritation of joint capsules and other soft tissue structures. This is something that we don't tend to think about a lot, but can often be problematic. Facets are an aspect of bones that can be problematic, such as facet arthritis. Obviously, nerves can be an issue, or vision-related problems. So the vision-related problems can cause compensatory musculoskeletal problems, but also just the vision in and of itself can be an issue. So refraction, convergence issues. I had one pediatric patient who had been having chronic headaches because of convergence issues. And when after they did visual PT, where they retrained those muscles, the headaches got a lot better. And then different types of glasses can also be an issue. So this is mostly the case with bifocals or trifocals, where people have their head at certain angles for long periods of time. So with circulatory issues, any impediment to the flow of blood and or lymph can cause pain. This happens because of the mass effect on nearby pain-sensitive tissue, compression of the periosteum, which is pain-sensitive, or non-optimal arterial 2 or venous supply outflow, non-optimal arterial supply to and venous outflow of the target tissue. So the target tissue is either not getting enough nutrients, or the toxic buildups are not being brought away. The metabolites are not being brought away properly. Can also have an impact on muscles. So chronically hypertonic muscles usually have worse circulation, and that goes back to our previous point about not having enough arterial flow to the muscle and not getting those metabolites moved away from the tissue. Lymphatics are a recently discovered lymphatic system in the CNS. So when I was in medical school, like 15 years ago, pretty much, they were still talking about the CNS as not having a lymphatic system. And within the past 5 to 10 years, researchers have found actually the lymphatic system, which is parallel to the venous system. And it has been demonstrated to clear waste material and proteins from the parenchyma of the brain. And so the research is emphasizing the possible effect on dementias, post-concussion syndrome, and neurodegenerative diseases. And from the OMM side, this may be a way to explain how OMM and cranial can affect headaches. That's a speculative thing that we need to do more research on, but it is interesting that now we have a demonstrated lymphatic system. We can see its flow. We can work on it from an experimental perspective. And so perhaps this is something that can explain how cranial can affect headaches. From the muscular perspective, if the neck doesn't move as much, if you have a reduced range of motion, that's going to indicate a cervicogenic headache. So if you have muscle tension, that affects arterial and venous flow, but it can also impinge on the nerves and the fascia. So if the muscles are tight, that's going to also tighten fascia. That can affect the nerves that go through the muscles and the fascia. Trigger points are also very common with tension headaches. So remember that trigger points are tender points that refer pain or other symptoms elsewhere. So if you push on a trigger point, the patient is going to say, "Ow, that hurts in my head," or something like that. And then you know it's a trigger point. Because if you just push on the tender point and they say, "Ow, that hurts where you push," that's not a trigger point. So Dr. Travell is a MD PM&R doctor who wrote a lot about these. And she's the one who established a trigger point manual, volumes 1 and 2, that are now in their 2nd edition. And these points are usually the ones that are targeted for Botox or lidocaine injections or dry needling. And they can be very helpful, these procedures. So just a reminder of anatomy here, you've got your suboccipital muscles, and you've got your arteries, you've got your nerves going through the fascia and the muscles. Sometimes the nerves actually penetrate through these muscles. And so if you have a really tight muscle, that can cause radicular pain, such as sciatica. The same sciatica with the piriformis syndrome. Okay, got that. So the myodural bridge, and this is a paper from 2013. So what they did in this research paper was they looked at 11 cadavers. They found a tendinous matrix that went from the rectus capitis posterior major into the posterior cervical dura mater in all specimens. So the rectus capitis posterior major is this big muscle right here. And they're saying that there was a tendinous attachment, or a tendinous matrix, from this down here into the posterior cervical dura mater, which is really pretty remarkable, because that means that there's a direct connection between the cervical muscles and the dura, which unfortunately they didn't have any of the people's medical histories, but it would be interesting to see if they had chronic headaches, because you would think that, right? Um, the other thing, about this study is that they only looked at 11 cadavers, so we don't know how prevalent this anatomical finding is in people. So I hope that there is going to be more of an extended look at this at some point, because it would make a big difference for headache management and cervicogenic headache management as well. They did look at one specimen. They looked at it for neural tissue, and it did show proprioceptive fibers. So this just goes back to the original point of the proprioceptive properties of a lot of these suboccipital muscles, and how that can affect things like cervicogenic vertigo. And that's the paper if you want to read it. So ligaments and joint capsules can be sprained or torn. And when this happens, it affects the neck as a whole, and that can cause pain and instability. So this can obviously occur in whiplash type injuries or football injuries, anything where the neck is whipped around. That can sprain these ligaments in between the vertebra. It can also affect the soft tissue of the joint capsules. So to rehab this, strengthening the muscles in the area can be helpful. And you may also need to consider prolotherapy. So what prolotherapy is sclerotherapy. That's another word for it. But what you do is you strengthen the ligaments by injecting an irritating substance. Often this is dextrose, which is cheap and very available. And that causes fibroblasts to proliferate, and that rebuilds that connective tissue. You can also use platelets. So that's known as PRP. And the regenerative medicine is something that's you'll often hear about with athletes. Like Tiger Woods has had a lot of this regenerative medicine, these procedures. Cervical facets can also cause pain referral when irritated. So in this particular study, what they did was inject something that was irritating into these areas and then note where people had pain. So when they injected the atlanto-occipital area, people had pain in this light gray area. And when they injected T1 to 2, they mostly just had pain around the T1 to 2. But you can see that OA irritation can send pain to a lot of areas of the head and the neck that you might not necessarily associate it with. This is another example of another interventional study where they injected an irritating substance and noted where people reported pain or symptoms. So with that OA, a lot of people had pain in the back, where you would expect, but some people had pain in the frontal region and along that temporal region as well. C2 to 3, which if you remember from a few slides ago, when this was blocked, when they injected an irritating substance to C2 to 3, 70% of people had headaches from this. And then you can see here that there's a pretty wide distribution of symptoms when this is injected. Basically, the takeaway point here is that any of these facets or vertebral areas will refer pain if irritated. So if you've got somebody with cervical arthritis, that will often cause headaches. Specific nerves with cervicogenic headaches are the greater occipital nerve, lesser occipital nerve, and the C3 dorsal ramus. And I wanted to talk about the trigeminal pathway here, because it is another important aspect of cervicogenic headaches. So if you've got somatic dysfunction in the cervicals here, that refers pain to the head through the trigeminal pathway up there. And that goes up to the midbrain, pons, thalamus. So this part here, that the cervical somatic dysfunction referring pain through the trigeminal pathway, is thought to be involved in the pathophysiology of migraines. As a reminder, the trigeminal nerve innervates the dura here. And this is another picture of referred pain patterns after injecting the upper cervicals. So when you have irritation in the joints, that goes into the trigeminal pathway, and then unfortunately, this is referred to the same field in the thalamus as the head and the face. So the brain can interpret the cervical signals as being headache-related pain, but it's actually referred pain from the neck. So the other anatomy study I wanted to talk about here was one where they looked at the trigeminal nerve afferents, looking in post-mortem rats and humans. So the nerves actually went from the meningeal structures through the sutures to the temporal and upper neck muscles and the temporal parietal and occipital periosteum. That's really interesting because I didn't, I knew that they affected the meninges and all, but I didn't realize that it went through the sutures to the temporal and upper neck muscles. And so the authors suggest that these serve nociceptive and proprioceptive functions, and the afferent signals are going through the trigeminal pathway. And this may explain the aggravating influences of neck muscle tension on tension type headaches and migraines. So not just the tension type headaches like we've often thought of, but also migraines, and may explain why manual therapies of pericranial structures can be successful in the management of headaches. So this was super interesting to me, obviously, since I do manual medicine, because we can see here there's more of an anatomical explanation for why this could be helpful. So with our patient, he had a lot of different things that could have been contributing. So he had an established history of migraines, but he also had a recent worsening of the severity and types of auras and symptoms, and probable trigeminal involvement, just based on anatomy. He also had lots of musculoskeletal tension, often gets thrown by his cows, and that increases the musculoskeletal tension. He'd had at least one previous concussion, probably more subconcussive hits, frequent sinus infections. The headaches did improve after sinus surgery, but they didn't go away completely. And he also has anxiety, which, as you know, it just makes everything else more complicated. So the anxiety can feed forward into a positive feedback loop, and then it just makes the headache symptoms worse, and then the anxiety gets worse, and the headaches get worse. And so any intervention that's going to help is going to have to also involve dealing with the anxiety aspect of this. Okay, so let's talk about treatments. So let's see, I've been out of family medicine residency for 7 years at this point. And so I've seen a lot of different varieties of headaches. So what I've found is that OMM is usually helpful if the headaches are cervicogenic, tension, mixed migraines, post-concussion, or secondary to dental appliances. And if it's TMJ related, OMM is usually helpful as well. OMM is sometimes helpful with migraines, because migraines can be very tricky. If they're a mixed migraine, like a tension and a migraine headache, then OMM is usually more helpful. But if it's just a straight migraine, not always very helpful. Chronic daily headaches are sometimes helpful. New daily persistent headaches, sometimes helpful. Arnold-Chiari syndrome that is not severe enough for surgery, it can be helpful. We had an OMM clinic patient. This wasn't my patient, but she'd been having chronic headaches for a while, and then she got diagnosed with Arnold-Chiari, and then she had a shunt put in, but the shunt malfunctioned, as they do, and she kept getting headaches, but she couldn't go back to the neurosurgeon because of insurance issues and the fact that the original neurosurgeon had moved, and so that, you know how these things go. It was very complicated management. So anyway, so we couldn't get her in to see like an appropriate neurosurgeon for a while. So she kept coming in every week for OMM to see if that would help. And actually, she said the headaches would go away. The headaches from the pressure buildup would go away after OMM for at least 4 or 5 days. And so we were like, well, I mean, if it's working well enough for that, that's good. But you need to get, but you need to get surgery. You know, I mean, it was sort of a solution that was partially successful, but it wasn't going to be the main solution for the problem. So we got her into neurosurgeon eventually, thank goodness. But in the meantime, we could do enough OMM that it would help with the symptoms, enough that she could keep working. OMM is sometimes helpful with pseudotumor cerebri as well. But as you know, there's a lot of there can be, I should say, there can be a lot of psychological overlay with pseudotumor. So that's a little bit more tricky. Trigeminal neuralgia, occipital neuralgia, or atypical facial pain can be sometimes helpful. Cluster headaches are very difficult to treat. Sometimes it's helpful, but usually not. So you can usually affect some characteristic of headaches. So duration, frequency, or intensity. I make it a point when I see patients in clinic or in the hospital not to promise a cure, because their definition of improvement and your definition are very different. My definition of improvement is really significant reduction in symptoms or complete resolution. That's what my goal is. But for a lot of patients, as long as you can get them functional to about like a level 3 or 4 out of 10, that's good enough for them. So also important to talk about contraindications. If there's a suspicion of a non-benign etiology, finish your workup first. If you've got acute fractures, don't do OMM. If they've got neoplastic bone disease in the cervical spine or skull, don't do OMM. If there's acute trauma to the head of the neck without a complete workup or established diagnosis, that is not the time to pop somebody's neck. And of course, HPLA is contraindicated in connective tissue disorders, especially Downs and rheumatoid arthritis. Okay, so treatment modalities for headaches, the ones that are musculoskeletally targeted. So OMM, obviously, you want to be careful about selecting your technique because you can make headaches worse sometimes if the techniques are too vigorous, such as HVLA or muscle energy, where the patients are pushing too hard, that can make things worse. You can also show the patients how to do some exercises for their neck. Massage can be helpful, trigger point modalities, acupuncture, facet blocks, Botox injections, or prolotherapy. You can also do nerve blocks, epidural injections. That's mostly, I feel like that's mostly helpful if they've got a lot of cervical arthritis. Medications, Dr. Jay Johnson did a great presentation at the STAB Symposium about the newer medications for migraines. So if you haven't listened to that, it was fantastic. Magnesium supplements are helpful sometimes for chronic headaches. So the American Academy of Neurology recommends 250 milligrams BID for magnesium to help with headaches. And you just want to caution patients that it can cause diarrhea. So usually I start 100 or 200 milligrams Q day and then move it up if they're doing pretty well. If they need surgery, they should get surgery. Also, there's some newer devices such as transcranial magnetic stimulation for migraines and transcutaneous vagus or nerve stimulation for the vagus and trigeminal nerves that can be helpful. And some of the devices are FDA approved. So from the OMM perspective, you want to start with screening the upper thoracics and treat that if needed. So when you think about the anatomy of the neck muscles, many of them have attachments to the sternum, clavicle, and upper thoracics. Then you also remember that the sympathetics for the head and the neck are in the upper thoracics as well. You assess the neck, the vertebra, anterior and posterior cervical musculature, do an OA decompression. I will also mention that if you've had somebody with a whiplash injury, you want to check that anterior cervical musculature because sometimes they can still have significant anterior cervical muscle tension for years after a whiplash injury. And that can be the big driver for neck pain and headaches. And then you also consider the fascial restrictions of circulation, which is what the venous sinus drainage does. So with OA decompression, this is, I would say, the most important technique. There's some subtlety to it. Sometimes people will put their fingers in the wrong place. So to get away from that, you can slide your fingers up the neck till you hit the occiput. Then you change the angle of your fingertips so that they're more vertical, and this should get your fingertips directly into the OA space. Otherwise, you're pressing on the occiput or you're pressing on the C1, C2 region. This is a way to get your fingertips in the right place. So venous sinus drainage affects, so you're working on the bones that affects the dura through the sutures. And that affects the lymphatic and venous drainage. So a diagram here, just looking at the internal layer of the dura, that's the meningeal layer, and the external layer of the dura. So when we work on the venous sinus drainage, we're affecting the dura because it divides around the bone, and you're pressing on the external part of the skull and affecting the dural tension on the inside. Okay, that's all I want to say about that. So our steps are the OA decompression, confluence of sinuses release, occipital sinus release, condylar decompression, transverse and straight sinus release, and the sagittal sinus release. So we got the OA decompression, we talked about already, confluence of sinus, occipital sinus, condylar decompression. Obviously, we're not touching the condyles because there's a lot of muscles and other tissues in between your fingertips and the condyles. But what we're trying to do here is just affect the muscle tension around the condyles. The transverse and straight sinus release, sagittal sinus release. This is the cross thumbs technique up to bregma, and then you work on the frontal bone itself. So different stretches you can teach the patient. The chicken neck. I like to do this one because a lot of people have forward head posture, and the chicken neck exercise helps with that. So you basically tuck the chin and you push your head back and then push the head forward like a chicken. So you stretch the head forward and back, and that helps stretch out those suboccipital muscles. You can also push the head in 4 directions against the resistance of the hand. When you do this technique, you don't want to tilt the chin up when you do this. People have a tendency, when you tell them to push backwards against their hand, to tilt their chin instead of actually pushing their head directly posterior. So that's one thing that I would caution you on. But otherwise, pushing in all 4 directions really helps with neck tension. It's basically a muscle energy technique that the patient can do for themselves. Okay, so in conclusion, headaches can be caused by a lot of different things. You want to rule out your dangerous things first, obviously. Cervicogenic headaches are, I would say, pretty common, and they can be caused by a lot of different structures in the neck. OMM is helpful for many types of headaches, not every type of headache and not all the time. You want to ask about the history of trauma and lifestyle and postural considerations, especially with neck issues. So I spend a lot of time talking about pillows and mattresses for people with neck pain or back pain for that reason. And then giving your patients neck exercises to do at home can be helpful because they feel like they have something to do to help themselves, and you don't need to see them as often. Okay, and this last picture is just a picture off the coast of Hawaii, off the Kona coast, just for fun. Okay, let me know if you have any questions, and thanks again for having me come and speak to you. These are my references here. Okay.